Welcome to the 2024 Southwestern Ohio Rural EMS Protocol Updates Training. I'm Tom Charlton, the Medical Director who edits these protocols. Let's get on with the training. As is typical for physician presentations, I have no disclosures to report. We will start today's training by going over the revised protocols, followed then by the new protocols. While this may look like a lot of changes, many of them are relatively minor or are placing emphasis on a piece of the protocol. The largest change is in pregnancy and postpartum complications. Special attention is needed when we get to that one. We only have 3 added protocols this year, however I believe that they are high yield. We start with a consensus agreement on how to define who a patient is and is not. We have adopted a protocol that Anderson Township Fire Department has used for several years, with some changes, so we can treat epistaxis. Things wrap up with a new calcium administration protocol that is referenced in several other protocols, and is useful in the suspected hyperkalemic patient. First, the revised protocols. Asystole was updated to refer you to the new calcium administration protocol. It was also updated to de-emphasize the endotracheal medication administration route. Intravenous medications are significantly more effective in cardiac arrests than the endotracheal route. Bradycardia has several minor updates. The protocol was clarified to reflect that a pulse must be palpable at less than 60 beats per minute to qualify for this protocol. A reminder that the electrical heart rate shown on the monitor may not always be reflected in the palpable pulse rate. Multiple protocols were updated this year to standardize midazolam, or Versed, dosing throughout the protocol. A handy drug dosing chart has also been placed with each protocol that calls for midazolam. The bradycardia protocol is the first protocol where you will see this change. Seizures was also updated to reflect the standard doses previously called for in this protocol. They are now presented in a dosing table similar to the other protocols with midazolam. I want to draw attention to the fact that midazolam 10 mg intramuscular is still the preferred first-line dose of midazolam for an actively seizing patient that does not already have access prior to the seizure. Hypothermia has 2 changes. Recent AHA guidelines have changed to reflect the lack of evidence supporting altered ACLS protocols in hypothermic arrests. The recommendation is now to treat hypothermic arrests similarly to other cardiac arrests. Follow ACLS guidelines with the addition of trying to rewarm the patient. A minor typo was corrected, reflecting that the appropriate temperature for warmed air rewarming is 108 degrees Fahrenheit to 115 degrees Fahrenheit. Hyperthermia and heat-related emergencies has several changes. There is significant evidence that commonly used means of obtaining a temperature, such as sublingual, axillary, tympanic, and temporal, are not accurate and cannot be relied upon for temperature-sensitive diagnosis. The only reliable method of core temperature measurement that EMS has access to is rectal. In order to obtain a true core temperature in a heat stroke patient, rectal probe temperatures should be obtained. In the absence of rectal temperature, patients suspected of heat stroke should be cooled by immersion cooling, which we will go over momentarily. A reminder that heat stroke is defined as a core temperature of greater than or equal to 104 degrees Fahrenheit plus neurological symptoms. If you are unable to obtain a core temperature, but suspect that your patient is suffering from heat stroke, you should actively cool them by immersion cooling. In heat stroke, temperature is brain. These patients have dangerously elevated temperatures that is actively damaging organ systems. Without rapid cooling, these patients are at significant risk of permanent damage and death. Even with aggressive cooling, a not insignificant number of these patients will have lasting neurological injuries or other injuries to their organs. Immersion cooling is the most effective way of rapidly cooling a heat stroke victim. Many sports medicine teams have now purchased their own immersion cooling devices. However, it is relatively straightforward to create our own for EMS. First, obtain a body bag. Place your patient face up in the body bag and begin dumping water, preferably with ice, into the body bag. The idea is to immerse as much of the patient as possible without obviously covering their head. Because of the logistics involved with this, it is best to cool the patient first, then transport. Trying to transport while having a patient immersed is not recommended. The patient should be cooled until mentation improves or their core temperature reaches less than 101 degrees Fahrenheit or for 20 minutes. At the 20-minute mark, you should contact medical control if the patient has not improved. If your patient has other medical concerns, such as seizure, respiratory failure, and other life-threatening emergency conditions, it may be appropriate to rapidly transport instead of cooling on scene. Please document accordingly. Additionally, if you are unable to obtain the necessary water with or without ice, it may be appropriate to transport with what cooling you do have available. Remember that this is not ideal and allows the elevated temperature to continue harming the patient. Cool first, transport second. Some patients with heat-related illnesses may suffer from dilutional hyponatremia. We have done a good job of educating the public that remaining hydrated in hot weather and while exercising is important. However, sometimes people will overhydrate using water. When patients are actively exerting themselves for a long time, typically during long-distance marathons or roofers, the body will lose a significant amount of our salts through our sweat. It's what makes your t-shirt crunchy after a workout. If all the patient is hydrating with is water, the remaining blood salts become diluted, lowering the effectiveness of those salts in your bodily functions. If you have a suspected heat stroke patient, but their mentation is not improving with cooling, the patient may instead be suffering from this condition. Contact medical control, discuss your concerns, and you likely will be told to transport the patient. Obtain IV access if able, with gentle rehydration if not otherwise hypotensive. Head or spinal trauma has several updates. New end-tidal carbon dioxide levels have been added. If the patient is actively being bagged, the respiratory rate should be roughly 10 breaths per minute, targeting an end-tidal of 35 to 45 millimeters of mercury. An additional note has been added calling out that there are 3 conditions we can prevent in the field that are known to worsen outcomes in head injury patients. These are the H-bombs: hyperventilation, hypotension, and hypoxia. Aggressively treat these conditions to prevent further harm to the patient. Major burns has several updates. Clarification was provided that after removing clothing, the patient should be dressed with a clean, dry sheet. IV fluid administration is now age-specific. Less than 5-year-olds should be guided by medical control. 5-year-olds should be given crystalloid fluids at 125 milliliters per hour. 6 to 13-year-olds should be given 250 milliliters per hour. Patients older than 13 should be given 500 milliliters per hour. The protocol has also deleted first-degree burns, etc., and instead now reflects modern thickness-based terms for burns. Administration of TXA added as criteria, quote, concern for severe internal or external hemorrhage, or a patient will likely be a candidate for a blood transfusion. A normal vital signs chart was updated for pediatric patients that qualify for this protocol. Crush injury patients are now shunted to the calcium administration protocol. This will be discussed later. Spinal motion restriction had several minor updates. Patients placed on a long spine board should be log rolled off of it and secured to the stretcher mattress prior to transport, as long as it does not significantly delay treatment or transport. Children presenting with a twisted neck should be presumed to have a cervical spine injury. They should be placed in a collar or otherwise immobilized. A reminder was added to work with your local sports medicine teams on an immobilization plan if you routinely respond to athletic events. There are currently conflicting position statements between the sports medicine community and the EMS community on proper spinal immobilization. Working with your sports medicine colleagues ahead of an emergency is preferred to a tense scene in front of a crowd. Do what's right for the patient in the moment, remembering that EMS protocols trump scene interveners. Hypertension in pregnancy is a national maternal problem. Hypertension in pregnancy contributes to maternal and fetal morbidity and mortality. Strong evidence supports the need to aggressively manage pregnant patients with hypertensive crisis to avoid bad outcomes. While new to our protocol, these changes have been in place within obstetric departments for some time. Only a few states in the country, California being one, have pushed for better treatment of this condition by EMS. For this protocol, the patient must be pregnant and have a systolic blood pressure of greater than or equal to 160 millimeters of mercury and/or a diastolic blood pressure of greater than or equal to 110 millimeters of mercury on 2 occasions, taken at least 15 minutes apart. In order to treat this condition, we are adding a new medication to the drug box, nifedipine. This is a calcium channel blocker and is safe for pregnant patients. If your patient meets this criteria, administer nifedipine 10 milligrams by mouth every 15 minutes to a maximum dose of 45 milligrams or 3 tablets. If your patient's blood pressure improves to below protocol criteria, stop administering additional nifedipine. If you initiate treatment with nifedipine, notify the receiving hospital that the patient met criteria for a hypertensive crisis in pregnancy and was given nifedipine. That wraps up the protocol edits. We have 3 new protocols to train on still. The definition of a patient protocol was added to help clarify situations where it is unclear on whether a patient really is a patient or not. This protocol has both a text and flowchart portion to make referencing easier. Unless the person meets the definition of a patient, they can be considered not a patient. It is important, though, that you follow your agency's documentation SOG SOPs on how to document these not a patient encounters. It's also important that you read through the protocol. This is the flowchart within the protocol. There are a series of yes or no questions to answer to direct you as to whether the person is or is not a patient. Patients are defined in protocol as, quote, any person who identifies him or herself as requiring medical assistance or evaluation, or any person who has a physical or medical complaint or condition from an illness or injury. An adult may be considered not a patient if all of the flowchart criteria are met. Minors and others deemed to lack capacity should by default be treated as patients. The new epistaxis protocol fills a current gap in our existing protocols. Anderson Township Fire Department has been using a similar protocol for several years with good success. This protocol applies to patients 16 years of age or older with epistaxis of any cause. Patients with any of the exclusion criteria should not be treated by this protocol. Exclusion criteria is a known allergy to oxymetazoline, otherwise known as Afrin, or neosynephrine, a known or suspected skull fracture, a known or suspected intranasal foreign body, or a known or suspected intranasal surgery within the preceding 45 days. Agencies are given the option of choosing oxymetazoline or neosynephrine. Literature does not support one medication being superior to another. When treating epistaxis, it's crucial that the caregivers are adequately protected by PPE. A sneeze from an actively bleeding nose sprays everywhere. Gather your equipment prior to treatment so you are prepared. First, have the patient blow their nose to forcefully remove any blood clots. The patient may need to repeat this several times. When the patient can get airflow through the nostrils again, the nasal cavity is adequately evacuated. If you are a paramedic, you then should administer 4 puffs of nasal medication into the bleeding nostril, timed with the patient's inhalation. If you are unclear on which side is bleeding, apply the medication to both nostrils. Patients with COPD and oxygen dependency must be monitored closely, and it is generally not recommended to apply nasal clips. All other patients should have a nasal clip applied to the soft part of the distal nose. The goal is to compress the nostrils and septum. Ideally, keep the patient sitting upright and head tilted slightly forward. Closely monitor your patient and avoid having them swallow or aspirate blood. Having suction readily available along with emesis bags or basins is important. Our last new protocol is for calcium administration. Previously, several protocols referenced calcium administration. This protocol puts all of those under one umbrella protocol. Inclusion criteria include age of 16 years or older, cardiac arrest with suspected hyperkalemia, or suspected hyperkalemia with EKG changes consistent with hyperkalemia, or crush injuries. These rhythms may include normal sinus tachycardia, atrial fibrillation with or without rapid ventricular response. If other rhythms are present, treat per their relevant protocol. Contraindications for calcium administration are hypercalcemia and digoxin toxicity. There are 2 main types of calcium used. Each agency may carry a different type of calcium, and some may choose to carry both. The 2 most common forms are calcium chloride and calcium gluconate. Calcium chloride has 3 times as many calcium ions per gram than calcium gluconate. It is the preferred agent in emergency situations such as cardiac arrest. It, however, carries with it the risk of severe tissue necrosis if it extravasates. Calcium chloride may be diluted in normal saline or D5W to prevent necrosis should extravasation occur. If it is to be given in the same line as sodium bicarbonate, you must flush 20 milliliters of normal saline prior to and following the calcium administration. For cardiac arrests, you should administer 20 milligrams per kilogram to a maximum of 1 gram IV push. You may repeat this as needed. In severe hyperkalemia with EKG changes, you should administer 500 to 1,000 milligrams, a half gram to a full gram, diluted in 50 to 100 milliliters of normal saline over 2 to 5 minutes. You may repeat this if EKG findings persist. For crush injuries, you should administer 500 to 1,000 milligrams, diluted in 50 to 100 milliliters of normal saline over 2 to 5 minutes. It is important to follow the crush injury protocol when encountering crush injuries. Calcium gluconate has significantly lower risks of infusion site reactions should it extravasate. In cardiac arrest, you administer 3 grams IV push. Calcium chloride is still recommended as the first-line agent for cardiac arrest, however. For severe hyperkalemia with EKG changes, administer 2 grams IV push. You may repeat after 5 minutes if EKG changes persist or recur. In crush injuries, you administer 2 grams IV push, again following the crush injuries protocol regarding overall treatment of crush injuries. A dosing chart is included within the protocol for easy reference. That concludes the 2024 EMS protocol training. Thank you for your attention. Should you have questions regarding the protocols, please discuss with your officers or medical director. As always, I welcome suggestions for clarification, formatting, and content. Email me so we can start the discussion. Thank you again for your attention.